And you know, so I sort of got myself together and ended up finally getting into university after living overseas for a year, and studied computer science because I always liked computer games. And don't ever let anybody tell you that like where you go to school or what you major in is what defines your career, because it's so not true. I majored in computer science and I'm a CEO. Um, in fact, the first job you get and the internships that you get just before that, that drive your ability to get that first job, those are the things that really help you to get your career defined. Because what will happen is, so I graduated top of my class in computer science and I had two different job offers. And one of them was to write software to help NPR raise money. And this was way before maybe you were born, in the early 90s, 94. And the other one was to work on this thing called the Human Genome Project at MIT. And I, you know, had no idea what a genome was, but it was, and the pay was worse, but it seemed kind of cool. I kind of wanted to go to MIT, and this wasn't actually going to MIT. This was like just working in a lab. And so I took that one, and now I'm still, I don't know, I'm just about to be 50 years old, and most of my career has been in that genomic space. And the TED Talk that Anita mentioned, you won't recognize me. I had hair back then, but that TED Talk is also about genomics, and now I'm running a healthcare company. So that's a like not at all linear way to describe one's background. I've also gotten an MBA from MIT. I've run, I think, 5 or 6 companies. I've totally destroyed 2 of them, like run them completely into the ground on fire, lost millions of dollars for my investors, and I've had success too. And the successes are rewarding and the failures are how you grow. I'm so thankful for them, even though one of them cost me, you know, like a marriage. And it's that's the way life is. Embrace those for sure. So let me not just blab on, and I'll pass it back to you, Anita.
Well, great. Failures are how you grow. Ooh,
Mm, yeah.
deep.
Is it? I mean, everybody, right? You've like, because they hurt. The people that are like the biggest, most successful versions of themselves are the ones that have been the smallest, least successful versions of themselves. Because it, and particularly the younger, the better, because it imprints you. I never want to feel that way again. I will never do that again. Right?
Yeah. Yeah.
Problem with failure, Anita, is that like you can think about it in your mind, and it's as if you're failing at that very moment again. Even if it was something horrible that you did 25 years ago, it still hurts in that very same way. So we want to, like, when we think about our failures, not like sit in them emotionally, but like think about, yeah, that happened, and then look how we recovered. That's the critical thing to add on. So what does it mean to fail? It means, well, then I got up and kept going. Super
Yes.
valuable.
Awesome. So let's see where you pick back up, and let's talk about digital health for a minute. So, this is the Fireside NYC internship program. Life sciences, pretty broad term, encompasses biopharmaceuticals, payer providers, hospitals, medical diagnostics, technology, equipment, and digital health, which is a very fast growing field, especially in New York. So how do you define digital health?
I don't know. I mean, it's sort of like if it, you know it when you see it. Here's the thing. Like, healthcare is the most ancient sort of industry of humankind, and the way that we practice healthcare is the most ancient set of practices that exist. Like, technology that we're all used to as humans is so far ahead of what's happening in healthcare. So it's kind of cool because anything can be digital health. Anything from working for a company that develops electronic medical record software to sell to hospitals. Boring, don't do that. To I have a friend who's the CEO of a company called Ride Health. And Ride Health, they're just marginally in healthcare. Here's what their deal is. They go to the big health plans that insure you, and they say, hey, give us money, and what we're going to do is make sure that patients who don't have access to healthcare, that they get a ride. You're going to pay for the rides, but we're going to do it. There's almost like no healthcare going on. It's basically what they're doing is they're just like creating an Uber opportunity. And literally the company is a call center to get these patients who tend to be underserved, they tend to be poor, to get them to pick up the phone, to walk outside, to get into an Uber that's just come for them so that they can take them to a doctor's appointment. That's a digital health company. I mean, the board, the investors are digital health. So it really spans the gamut. And then anywhere in between, a lot of what we're seeing now, what Cureatr does, the company that I currently run, is around taking technology and using it to enable amazing doctors and nurses and pharmacists and so on to be sort of like 100 times better. So we call that tech-enabled services. That's digital health. What isn't digital health? Well, I guess if there's no digits, just kidding, if there's no software, hardware, technology, then I guess it wouldn't be. And if it's not really about healthcare, even in some distant way, then I guess it wouldn't be. But everything in between kind of is. And if you take the broadest definition of that, and I think most of what's going on in like New York healthcare innovation is related to or directly is digital health.
Nice. So I want to come back to that sort of the digital health innovation in New York. I just got an email from Uber, I think, saying, or maybe it was, I don't know if anybody else has seen this, but New York City and Uber are willing to pay for your rides to get a vaccination now. Is that something? Do you know if that's related to ride or?
I can text Imran and find out. I mean, that'd be a heck of a coup for him if that were the case. And by the way, to inspire the young humans that are listening, whether or not your camera is on, that wasn't a judgment, sort of. We'll come back to that. So to inspire those of you who are listening, Imran, who's the CEO of this ride health company, for example, he's like 26. This thing is funded by the same monster investors that fund Cureatr. Like, there's no one's ever gonna like give you permission to do that sort of stuff. You got to see a problem and you got to go and say, I want to solve that problem, and I can, because there's nothing that another human can do that I also can do. That's a critical thing that you should always be saying to yourself and proving it.
That is super inspiring.
Yeah, so I don't know much about that particular opportunity, but it'd be cool if it were my buddy, if you were behind it.
Yeah, made me feel a little sad because I did pay for one way for my first appointment. I said, shoot, I could have gotten that refunded. Oh,
Get
well.
a reimbursement, man. Go get it.
Yes, yes. Great. Well, you talked a little bit about changes in the digital health landscape. What have you seen personally, or what have you been able to see from your vantage point as a VC-funded firm in New York City?
All right, so I'll come clean. I'm not really a healthcare person. I spent most of my life in genomics, which in the broadest sense of that definition, yeah, it's part of healthcare, but it's really like R&D. It's sort of like developing drugs and compounds and tests to give to people who are in healthcare so that they can use them.
We learned all about the business of biopharma earlier today.
Good.
Yeah.
So do you guys think that's healthcare, or is that different? Raise your hand if it's healthcare. Yeah, sort of. Yeah. What I've discovered in running this company, my first one in healthcare directly, is that it's really different over here. Like, the customers are really different. We don't sell to big pharma. They got tons of money and they like to spend it, particularly to get drugs approved and to put stupid commercials on that your grandparents can watch at 4 p.m. That is to increase market share. In healthcare, there's so much more going on. Regulations. There's this weird payment model where like the health plans are paying for things on behalf of you, and you don't really know anything about that. It's like you're not really a consumer. You're sort of a captive. The big change in healthcare that I'll remark on that we exploit is that in the past, in our great country, health plans pay your providers, your doctors, for seeing you. So you go to the office and you get a physical, and that doctor gets $200, let's say. And then you pay $15 and your plan pays the rest, and that's that. So what is the doctor's incentive? It is to see as many of you as possible in as short a time as possible.
Stack that day, 15-minute appointment after
Exactly.
appointment.
Exactly. Regardless of the quality of the care, and regardless of whether that doctor is going to burn out. Did you know that the suicide ideation rate in doctors in the United States is like 7% higher than the national average?
Well, that's no good.
Right. It's no good. And it's because of that. So the big trend that I'm noticing that I'll remark on and then I'll move on is a new payment model called value-based care. Anybody hear of that? It's awesome. It's just right. Here's how it works. It's not perfect, but it's a lot better. Instead of the health plan saying, okay, doc, you do an office visit, here's $200. They try to bundle episodic care. What I mean by that is they will pay the doctor a fixed amount per month for every one of her patients, a fixed amount. And if the doctor is great, then these patients just need a little bit of care, right? Like whether or not they see the patients, they get the same amount of money. But here's the catch. If the patient gets admitted to a hospital, that costs about $16,000 on average. The doctor pays that. You see?
Wait. So the doctor gets a fixed amount per month
per patient.
Per patient. And the idea sounds like to incentivize them to stay out of the hospital?
To stay out of the hospital, to provide just the care necessary and no more. And so doctors that are really good at this, they're worrying not about what happens when they see their patient, but they're worrying about the patient's entire life. Because by the way, the vast majority of our patients' lives are lived outside of these settings. And so the health plan will there's sort of a typical admission rate. People get admitted to hospitals at certain rates based on their demographics. And so the hospital will, and so the health plan, what they'll do is they'll sort of say, okay, well, assuming this is your population, we're going to pay you this much. We're going to gross it up based on what we would expect the admission rate to be for you. So you really have an opportunity to make serious money because those $16,000 price tags, they're kind of built into that per member, per patient per month thing. And so if you can just be a little bit below the average for patients that have the same level of risk in you, you're making a ton of money and you're doing right for the patients. And if you're a little bit worse, that's just, hey, you're just paying hospitals bills, right? So this is a really important change that is sort of moving throughout all of healthcare, and digital health is one of the places that can exploit it the best, because if you need to know what's happening with your patients outside of a clinic, then you kind of need some technology to do that one way or the other. Make sense?
For sure. You got to figure out how to manage all of this new system, this new way of getting paid, new way of treatment, maybe even new way of thinking about how you manage your practice.
Yeah, exactly.
So we had a question come in. Might value-based care change doctors' behavior? So would doctors maybe not want to take on patients with challenging conditions, or say, hey, you don't need to go to the hospital?
So good. Great question. There's this weird thing that we do. So this is where healthcare just gets like eye crossing. There's a risk adjustment factor that you apply to patients based on their comorbidities. And so like if a patient's got, congestive heart failure and diabetes, instead of paying you X dollars per patient, for that patient per month, we're going to pay you X times some multiple, right? So there's all that stuff. And now you can imagine, well, that sounds like there must be people who have to do that risk adjustment. So yes, indeed, there are stabs of people in provider organizations that sit there trying to maximize their payment from the health plans by adjusting for risk. And if they can discover some new thing that's sick about one of their patients, they're thrilled to put that in. Another great opportunity for technology. So like, yes, that's an amazing question. Lots of holes in value-based care. There's generally a mediocre answer to a lot of them and a really good one to some, but that's a great insight.
Cool. So I want to get into a little bit more about Cureatr and your company, maybe starting with just how things have been over the pandemic. You recently closed a round of funding, saw that published. So congratulations.
Thank you.
What's it like to raise money in the pandemic?
It's kind of like, it's no different than normal. Here's the thing about raising money. Venture capitalists are herd animals and they're greedy. And if you seem desperate, if you seem like you're bleeding, then they're going to say, wow, that's cool. So they're going to slow play you. They're going to, right? And if you're like taking off and you don't need them, and you create scarcity, then they're all over you. And the pandemic didn't really change that. The pandemic for Cureatr actually was our breakout year, right, Jake? I mean, it was like the year. I'm one of my director of marketing is here. I see his beautiful smiling face. It was like an opportunity for Cureatr to die, and we came pretty close. But the way that we survived was to ask ourselves, how is it that we're not just going to survive, but that we're going to be 10 times better? We're going to help along the way. And so we, sold off a business line. I mean, our investors were like, we were going to run out of money in August of 2020. And our investors were like, prove that you got something here, because they'd been in Cureatr for a long time, far before Jake and I joined. We needed more time. We hadn't proved it. We have now, thank goodness. We hadn't proved it. And so we had to sell off a business line. But the best thing that we did, that Jake was like right in the middle of, was we just said, okay, screw it. Everything's free. Because you remember what it was like back in March or April 2020. Everybody just wanted to help, however that might take form. And so, I had this frank conversation with our board, like, because we have to pay every time we do things with patients. Like, there are real costs. I said, like, we're going to do it. We're going to spend this money. And they kind of see by my eyes that there was no way to say no, but it was hundreds of thousands of dollars that I was committing us to. And it turned out that giving stuff away for free, like, really did help to keep patients out of hospitals and really did save lives. And then when the free stuff was taken away, which is the sort of thing, I mean, we are a commercial venture, and the pandemic sort of became under control. Everybody was like, no, wait. And they started to buy it. And that's how we figured it out. And all of a sudden, at the end of 2020, we were trying to raise the same round of financing that we had forever, and it was oversubscribed. People were all over this round. So, like, the pandemic helped us to figure out what our actual business was,
Nice.
But money raising is kind of the same, no matter what.
I'm thinking that I should step back and say, what do you mean by tech-enabled services? What is this product that you were giving away for free that you have a charging model for, which makes sense? You're a company that offers a product in exchange for revenue. So what is this product? What do you guys do?
Yeah, I mean, well, we weren't a tech-enabled service. We were just a software company, data company, and we were trying to sell that and having a hard time. And as we started to give it away and people started to take it up, some of those users were like, man, this would be great if we could use this with your clinicians, assuming that we had them. And so we said, yeah, sure, no problem. We hung up the phone and looked at each other and said, shit, we better go get some clinicians, right? And so the nature of our business, what we do, and we've done that now. So what we do is you probably have relatives, parents, grandparents who take a lot of medication from 3, 4, 5, 6 different medications, maybe prescribed by 2, 3, 4 different doctors. Well, your primary care over here, your cardiologist, you're on call, like, right? Guess who is worrying about how all those things work together? Nobody. Now, in the setting of value-based care, every one of those prescribers is about to get hit really hard when that patient shows up at the emergency room because of a drug interaction that was harmful, right? So what we have is we've got all of this data, only when consented. So I can't look at any of this unless you give me consent. But if you were to give me consent, I could know immediately, in real time, the moment you walk into a pharmacy and you pick up a new medication. I know in real time whenever you visit any doctor anywhere in the country. I know everything that happened inside of that office. I know your height, your weight, your social demographics. I know your complaints. I know your diagnoses, your lab results, all
Right.
of it.
This might make some of us a little uncomfortable. What
I
is this information that you have access
I
to on
can't touch
everything?
it without consent and only to treat, only to treat. And
Okay.
if I were to violate that, or anybody at Cureatr would, not only is Cureatr dead, but like we'll go to jail, and like no job's worth going to jail over. Sorry. So integrity is our first value. Um, that sounds an awful lot like what Google used to say, do no evil, and they're sort of doing evil now. But so far, so good. We also know the moment you get yourself registered in an emergency room. Okay, so with all that, we know all of your meds, we know you're supposed to be taking across all your different prescribers. We know whether or not you're picking them up, whether you bought them with cash, with a good RX coupon, with your insurance. And we give that to clinical telepharmacists. These are not the pharmacists that dispense your medications. These are truly clinicians. They work in hospitals. They are partners with all the other docs and nurses worrying about medication. And so what we do is we go to health plans like United and we say, listen, just give us your list of members, all right, the list of patients that you've got. And that's all we need from you. And we're just going to listen. And if they ever show up at a hospital and they get discharged, we're going to be the intake, because we know all the meds they were supposed to be taking before they came and what the docs there wanted them to take on the way out. And so we do all of that work. We keep people safe from medication mishaps. And we only charge the plan when we do that successfully. So that's what we figured out. And we've just moved from like trying to figure out what our business is. That's it. We were signing contracts with plans left and right. Now it's like, oh my God, the execution risk as we go from 0 patients a day to 500 patients a day this year is harrowing, frightening.
Sounds like you might need a good biz ops intern to help you out there.
Yeah, I mean, I think, Jake, we just hired a couple. I think we have 2 already, and I know 2 already, and I know that you guys already have amazing companies, but there's probably room for, another 1 or 2 if you want to work for the best company in the program.
Well, fortunately,
these are all committed interns.
you're preaching to the choir. Yes, yes. But I'm sure we all have friends.
Yeah.
So, Richard, you talked about integrity, your company values.
Mhm.
One of the themes for our boot camp is just bringing into perspective the events over the past year, the pandemic, health disparities, racial equity. Yesterday was the anniversary of George Floyd's murder. What does equity in healthcare mean for you and for Cureatr?
So first thing it means is to keep on being a sponsor of this program, because we learned everything that we now know and have adopted because of a woman who was an intern here last year named Lydia Fikru. And she's going to be the president or bigger one day. She's an African-American woman, Columbia. And she showed up here to be an intern like any one of you. And she's got a lived experience that we don't. And we're a bunch of, at the time it was a sort of a white male leadership team. And none of us are racist. None of us are nefarious. We're not intentional. But like so many people, we couldn't see like how privilege was racism. And what she did with all of the pain that she was going through in the midst of all that. We were all going through it, but we were trying to reconcile it somehow. With all that pain, worrying about her younger brother, who, was materializing to be, no surprise, a young Black man, and all the dangers that exist because of that. One thing that we do in our internship program, thanks to Jake, is every week our interns have to pick something in healthcare to learn about and to present to the entire company. Just something. And it's amazing. It's impactful for us because they're teaching us all sorts of stuff. I recognize I got 2 minutes. So Lydia just slowly chose topics that changed us, like, why people of color are afraid to go to hospitals because of the school to prison pipeline. and the same cops that were there waiting for the 5th grader to take him out when, you know, he misbehaved are the same ones that are in those hospitals. Like, why there's bias in the data and algorithms of healthcare, right? So she suddenly, like, she and others made visible that which was previously unseeable, which is that white privilege, you know, in a way that permanently changed us, permanently changed me. We've added a new corporate value around equity and anti-racism in healthcare. And for us, that means making sure that there's representation. Like, you know, we're a bunch of pharmacists calling people, and some of the people that we call, the majority of them are either on Medicare or Medicaid, which means that they're not necessarily wealthy, and Medicaid patients tend to be quite poor. And guess what? They tend to be African American. Oh, that's not a coincidence, my friends. That's racism that caused that, nothing more. And so how do we make sure that we have pharmacists that are from those neighborhoods, right? That our data reflects the things that matter to them. So there's a whole bunch of initiatives that I'm going to run out of time and not talk to you about, but it was a transformational summer for us. And it's really a cause of ours at this point. And frankly, when someday we're going to sell Cureatr and I'm going to move on to do something else, and it's going to be around this for sure.
Yeah. I know we have some pharmacists in the audience. So, and I think Josh was actually already raised his hand for a question. Before I move to that question, Richard, one last question for you. We've talked about failures. We've talked about equity. We've talked about what you do. What brings you hope? What about the New York healthcare system makes you hopeful as we move forward?
Oh my God, I really only have 30 seconds. I think what brings me hope is, I'm not going to talk about the U.S. healthcare, the New York healthcare system. There's some hope in there. I'm going to talk about the team of people that work at Cureatr, because what we've been able to do there is be authentic, to be ourselves, like, and to value everything that's different about us, and to sort of celebrate our failures, remember that, as well as our successes. And it's the best company I've ever worked for. It's a huge, hopeful privilege to be there for as long as they let me stay.
Awesome. Thank you.
Thank you.
So Joshua, I think one of our resident pharmacists, is that right? Okay, thank you, has shared. Do you want to take yourself off mute and ask your question?
Sure. So my main question is that a main role of a pharmacist is to review drug regimens and to mainly just ensure that they're safe for the patient. So you were talking a lot about the value-based plan for healthcare. And I was wondering, in this value-based plan, are pharmacists going to supposedly have a more active role in patient care? Or is it more just, as you were saying initially, networks of physicians that were managing what they prescribe themselves?
Joshua, I love that question. Come work for us. So it depends on who you ask. Pharmacists are as highly trained as docs. It is ridiculous. It's part of the sort of the ancient nature of healthcare that such pharmacists are only allowed to count pills and put them in bottles. Oh, and quite recently, we allow them to review medications to make sure that they're safe. This is bullshit. There are some states, Ohio, Washington, I think, and more coming, where pharmacists actually can write scripts. They can prescribe. And of all the people that I would ask to prescribe something for me, it would be the person most trained in medications, right? So that makes a ton of sense. We're firm believers of that. And as we work with our health plans, we're doing medication review for sure, but the broad swath of things that we're going to, I mean, there's just a ton of care that you can provide in this role. Guess what? What's the percent of interventions, clinical interventions, that involve a change in medications? Anybody know? Take a guess. 70-something%. Just like more than 2/3 of what we do in healthcare is we prescribe or deprescribe. Why is it that pharmacists aren't taking a more central role? So that's definitely a great question. We're on your side for sure. And it's a slow erosion of old useless norms to get the whole way there.
Thank you.
Thank you.
Does anyone in the audience have questions for Richard? And I am scanning the chat window and the raise hand feature, as well as videos if you want to raise your hand.
My favorite thing in the world is to help particularly young humans, because they're not poisoned yet by the things that can happen. And so if you'd prefer to reach out to me directly, Anita, I'm sure you'll give my email address to anybody if they want to do something more private.
Thank you. Thank you for saying that. So I hope interns, we're about to go for a break. I hope you've seen a different side of life sciences today, and some different perspectives on career pathing and what you can do as a CEO. Thank you, Richard.